patient is afebrile. So if you see an A in front of a word, it's always without. So afebrile, without a fever. If it's above normal, they have lots of terms for that. Could be fever, febrile, hyperthermia, depending on how high the temperature is. Could be hyperpyrexia if it's a temp above 105.8. So that's a very, very high temperature. Below normal has terminology as well. On hypothermia, that should be, no, that's right. I thought it said 98.6. 96.8 hypothermia, so it's less than normal. If you have a temperature less than 93 degrees, it severely starts affecting your brain and your ability to function. So you have loss of memory, very slow movement. When you have an extremely low temperature, you have a 70% risk of your heart stopping. So that's pretty high. And then the term that's for less than 86 degrees is poikilothermia. Okay. What kind of thermometers have you used? The what? Which one? Tympanic. For the ear, the Tempodot, oral, under the tongue, disposable. What did you say, mercury? We don't have many. Hopefully, if you have a mercury thermometer at home, you will dispose of it in hazardous waste. Temporal artery. So those are all listed on the next slide. Most of us, at this point in time, you have used a disposable thermometer. Some of the places, that's all they had. The electronic, we brought them with us in many cases and used them in our long-term care facility. The tympanic membrane is an infrared ear thermometer. Temporal artery is the only kind of thermometers used at Kaiser. And then I was mentioning the mercury. Some people still have them at home, those glass thermometers. If they have mercury in them, you should get rid of them. They're very hazardous if they accidentally break. You can't put them in the trash. You have to send them to one of those hazardous waste recycle centers. Okay, here's a chart of significant temperature references. So the normal in most hospitals, we're going to use centigrade. So get used to using the centigrade or Celsius, same thing. Celsius, centigrade versus the Fahrenheit. So 98.6 is equivalent to 37. There's always a range of normal. Very few of the patients that you took a temperature on had exactly 98.6, right? That's considered sort of the ideal normal, but very few people are right at 98.6. So that range for Celsius or centigrade is 36.4 to 37.3 or 97.5 to 99.1. So fever is anything 38 or over or 100.4 or higher. Low-grade fever, 38.8 to or 101.9. Okay, and then there's some more temperature findings looking at a very high-grade fever, 39.4. If you have a really high-grade fever, you have neurologic damage at 42 and 107.6. Your brain is literally getting cooked. Mild hypothermia, 34 to 36. Severe, less than 30. And poikilothermia, 20 or 68 degrees Fahrenheit. Just a heads up, don't memorize these numbers. We're going to talk about fever. We're going to talk about hyperthermia, hypothermia. It doesn't do you any good to memorize these numbers. What you need to know is what causes it, the physiology of a fever, for example. And you need to know what those signs and symptoms are, what causes those signs and symptoms, and what you're going to do as a nurse to fix it. So that's basically how you should study all the time. So don't be memorizing all kinds of numbers. It has no benefit to spend that time without knowing what to do with it. Okay, this is just a really quick review. Core temperature is what we're trying to measure. If we're going to treat a patient, we want to know what the core body temperature is instead of the surface temperature. You can have really cold hands because you're nervous, but that doesn't mean that your body temperature is hypothermic, right? So we want to have a core temperature, and that's the temperature of deep tissues in the body. The core temperature measurements can be made with a rectal thermometer, so that's always considered a core temperature. We don't take rectal temps very often. You will see it perhaps in the critical care unit when they're on cooling blankets and they may have a continuous thermistor in place, electronic thermometer, to measure what the patient's body temperature is while they're getting hypo or hypothermia treatment. Tympanic membrane is the ear thermometer. And why is that considered a core temperature?
Next to the brain.
It's next to the brain, and it's the tympanic artery is a branch of the hypothalamic artery. The hypothalamus determines your body temperature. So that's why it's considered a core temperature. The temporal artery, also considered a core temperature, can be very reliable. The central line thermistor is what you would see later on in the 4th semester when you get into critical care. It's basically an invasive central line that has a thermistor on it, and it measures the internal temperature of the blood as it goes through the pulmonary artery and through the right side of the heart. Oral temperature is very dependable. It's safe in alert adults. Most accessible, very convenient, and easy to take. Patients are not at all reluctant to do that. And then I talked a little bit about axillary temp. If oral temperature isn't accessible to you, the patient can't breathe. If his mouth is closed or they're confused, you couldn't take an oral temperature. But if they haven't had an issue with an axillary, with a high temperature, high or very low, you can take an axillary temp. It's easily affected by environmental changes, so it's not a good temperature to take if the patient has an issue with either very high or very low. Then you do not want to take an axillary temp. And then the surface temperature is the temperature of the skin when you touch the skin. And that's associated frequently with the temperature of the skin with the ambient temperature in the environment. So we're going to start with how to do each one of them. The temporal artery thermometer. There's a picture of it there. You put the probe in the center of the forehead, and then you depress the button that's on the side, and you keep it depressed as you slide the probe straight across the forehead to the hairline. So don't follow the hairline. You have to go straight across, not making a curve, because then you miss the temporal artery. So straight across, and then actually to the hairline, and then you touch that probe behind the ear, and at that point in time, you release it, and it'll show the temperature. So you're going to go behind the ear, sort of halfway across the mastoid process, and then remove it and release the button, and you'll get the temperature. So straight across, behind the ear, and then release the button. Okay, the tympanic membrane thermometer used to be really common, but a lot of nurses didn't quite like it. Why do you think they didn't quite like it? When they first came out, and they continued not to like it, but there was a reason for that. They didn't know how to use it. Yeah, you need to know your anatomy to use it correctly. So what they failed to do consistently was pull the ear up and back. And except for infants, it's back and down. And an adult, it's up and back. So pull the ear up and back, and the intent is for you to straighten out the ear canal. It has a little infrared light that needs to actually hit or glow on the tympanic membrane. So if you don't pull the ear up and back, the little red light that's going to detect the temperature isn't going to go around a corner. Okay, the light doesn't make it a U-turn type of thing or a 90-degree angle, so you need to straighten out the ear canal. That light needs to shine on the tympanic membrane in order to get an accurate temperature. So nurses would say, you know what, this thing just isn't working, and they'd go back to an electronic or an oral thermometer and they'd get a different temperature. But it's very, very reliable, very accurate if you use the right technique. So the problem was user error. Okay, so aim the probe at the inferior third of the ear canal. Make sure the probe penetrates at least 1/3 of the external ear canal and forms a complete seal. You don't want to see any part that's not sealed in the ear, and then you can actually get like I said, an accurate temperature. And tympanic membrane temperatures are accurate in euthermic. What does that mean? Normal temperature, hypo, low, hyper, high. Okay. And then as I just mentioned, those discrepancies are usually user error. Some of the hospitals on some units will use those tympanic membrane thermometers exclusively, and they'll have different thermometers on other units. Depends on what hospital you're going to go to. Okay, and then the electronic thermometer, the oral electronic thermometer, it generally is used orally, but how else can you use it? Axillary, rectal, works all different sites as long as you use the right probe and the probe cover for a rectal. So the actual measuring device, the probe itself, has a red tip on it if it's rectal. So our red for rectal. Do not use an oral thermometer in patients who are unconscious, if they're disoriented, if they have a history of seizure activity. So if they have epilepsy, you wouldn't take an oral temperature because you can't predict when they might have a seizure, or if they're shivering so severely that they might actually bite on the temperature probe and perhaps tear mucous membrane in the mouth. Okay. The rectal temperature is, like I mentioned, also considered a core temperature. It is not the favorite place for adults to have their temperature taken. Kids don't like it either. So we do have other means of taking a temperature now, that's tympanic membrane, the temporal artery thermometer, but sometimes you have to take a rectal temperature. Make sure you wear the gloves, hold it in place. You can't put it into the rectum. Leave it while you do something else, manage something in the environment that you need to take care of for the patient. If the patient were to turn, and again, it could tear the rectal mucosa, so you need to stand there, hold it in place, and then remove it after the time is up and the thermometer indicates that it has recorded the temperature. The electronic thermometer is inserted 1/2 to 1.5 inches. You should know that so that you can safely, because the actual probe is probably, what is that, 4 inches? So don't put the whole thing in. Okay, 1/2 to 1.5. Be surprised. You may think that that's common sense not to, but you should know that it doesn't go in all the way. The axillary site, the big thing is that it's an okay temperature to take if the patient doesn't have an issue with a fever, but as soon as they have issues with a high temperature, not a good site to take a temperature, and it's not accurate if the patient has chills, hypothermia, or severe drug-induced vasoconstriction. So keep that in mind for the axillary temperature. A little bit about how your body produces heat. Okay. Your body temperature, your body heat is continually being produced. What is that? What determines your body temperature? Your metabolism, or what generates, or what influences what your basal metabolic rate is? I'm sorry? I heard someone. No? What maintains your your basic metabolism, your basal metabolic rate. Not the pituitary, no, not the hypothalamus. No. Your thyroid. Yeah, so if you're hyperthyroid, you're just really revved up because you have a real high metabolic rate. And if you're hypothyroid, everything is pretty sluggish because you don't have enough thyroid hormone. Okay? So heat production is affected by your basal metabolic rate, which is directly affected by your thyroid and how much thyroxine output your thyroid produces. Also associated with muscle activity, and then your epinephrine, norepinephrine, and sympathetic stimulation, as well as a fever will affect heat production. We're taking a look at heat loss. There are a number of ways that heat can be lost from the body. The first one that's listed on your slide is radiation. So it's heat loss without direct contact. So if you're very lightly dressed, if you came to school today, for example, in shorts and a sleeveless shirt and flip-flops, you might have heat loss because you're not dressed appropriately for the current temperature. So heat loss, 60% is lost through radiation. Okay, so it's transfer of heat between the skin and your environment. Okay, so exposed body surface area would cause radiation heat loss, or heat loss through radiation. About 5% of heat is lost through conduction. So that's heat loss with direct contact. So if you're taking a cold shower, if you're at the beach and all they usually have is that cold water, and you're already cold to begin with, that heat loss would be the body's contact with the cold water. Or a cooling blanket. In the hospital, we would have cooling blankets perhaps to get a temperature down. So conduction is transfer of heat from one molecule to another when there is direct contact between those molecules. So there's direct contact between the body, the skin, and the cooling blanket or the cold shower. Another conduction would be in the OR. Lots of patients come back with pretty low temperatures. First of all, the ambient temperature in the operating room is pretty low. They keep it pretty cool, right, to reduce the basal metabolic rate of the patient. And they use sometimes cool solutions to prep the skin with, cool solutions or cold solutions to irrigate the wound. So that would be loss of heat through conduction. Okay, the third one is convection, and about 15% of heat loss is through convection. So it's heat loss by air currents or a fan. So the ambient temperature is cooled down by a fan or air conditioner or whatever that might be. So it's air currents that move over the skin. The last one is vaporization or evaporation. Same thing, it's loss of moisture from the respiratory tract and from the skin. And as the body temperature increases, the vaporization increases too, because you start to generate sweat, right? So that would be vaporization or evaporation. So loss of insensible loss normally, or increased loss when you are very, very hot. So heat loss. What kind of patients have the greatest risk for heat loss? Burn patients, because the layer of skin that maintains your temperature, your body temperature, that layer insulates you from the ambient temperature. What other kind of patients? What kind? Newborn. Yes, absolutely. We got to keep these little newborns warm. We put little hats on them and we swaddle them in blankets. The other side of the spectrum we just learned about in Module 3, those older adults. Why are they at increased risk to become hypothermic? What physiologically puts them at greater risk? Less adipose tissue, so they've lost that layer of insulation under the skin, all of that layer of adipose tissue and subcutaneous fat, basically what we call it. What else? their sweat glands aren't working very effectively. They have difficulty sweating to get rid of heat, and they have difficulty retaining heat because of that loss of that subcutaneous layer of fat. What else happens if you get cold? Physiologically, what does your body do? So before you start to shiver, physiologically, what is your body going to do?
Blood to your core.
Shunt the blood. So the blood vessels vasoconstrict, right? So they vasoconstrict so that not so much blood is in contact with the body surface area of the extremities, for example. So with the vessels constricting, it retains body heat. So what's the problem with older adults? What happened to the blood vessels? They become narrowed because they have atherosclerosis, and they have less elasticity to respond to changes in, for example, heat and cold, because that's called loss of elasticity of the vessels in older adults is called arteriosclerosis. So if you normally would get cold, your vessels respond very quickly. The same concept with orthostatic hypotension. Those blood vessels in older adults don't constrict quickly enough to allow that blood not to all rush to the extremities when they stand up. That's why they have greater risk for orthostatic hypotension, because those blood vessels are stiffened. So they have arteriosclerosis and atherosclerosis that keeps them from responding quickly, and when it comes to temperature, the same thing happens. They can't respond quickly to temperature changes by vasoconstriction or vasodilation. Okay? And what's another reason older adults are at greater risk for hypothermia? Yeah, we mentioned the subcutaneous fat. We mentioned arteriosclerosis and atherosclerosis, the vascular system not being able to respond. What else do they have less of? Muscle mass, right? And what's the other mechanism that they don't respond to well is when they get cold, they don't shiver. Their metabolic rate and their body's response doesn't respond to the shivering due to a multitude of things, including that arteriosclerosis. Just a quick review of Module 3. Okay, so a little bit about regulation of body temperature, and you probably remember this from physiology, I hope. Maybe? Okay, you have sensors in your skin and in the core, and those skin receptors detect cold and hot. The cold detector is a little bit more efficient than the warm detector, so that's why a lot of people don't like cold. They feel that sense of cold much more than they have issues with being too warm. The hypothalamus sets the target temperature. Pretty well keeps your body temperature your whole entire life at a pretty consistent level. So if heat is sensed in the periphery and around the hypothalamus, and it's below the set point, the hypothalamus will respond and then trigger heat conservation. So heat conservation is generated by vasoconstriction, because if the body has to retain heat, it'll just constrict those blood vessels with much less contact than with the skin. And then if that doesn't work, so that's the first level of response, if your body senses that it's getting cold. The first response is vasoconstriction. If the vasoconstriction doesn't work, the next thing is piloerection. What is that? The hair stands on end, and so the hair stands on end, called piloerection, but what does that do? It traps the heat between the little hairs, forms a little insulated layer of warmth, and then tries to retain some of that heat in the periphery. And if that doesn't work, the next thing is shivering. So shivering generates or requires an awful lot of oxygen and energy. So that's why in a hospital, We don't want patients to shiver. We do whatever we can when patients have an issue with higher low temperatures to keep them from shivering. We'll talk about what the effects of shivering are in a sick patient. So if the heat is sensed in the periphery and around the hypothalamus, and it's above the set point, the hypothalamus triggers heat loss. So the body triggers heat loss by vasodilation of cutaneous circulation, so the skin, and increased sweating from the sweat glands. And again, older adults don't have that increased sweating because the sweat glands are not functioning at the same level as it has in younger adults. So if heat is sensed, the body tries to get rid of the heat by vasodilation of the periphery, and by vasodilation there is more surface area in contact of those peripheral blood vessels with the tissue, with the skin, allowing it to dissipate the heat. Okay, so what are some of the factors that affect your body temperature? We talked a little bit about age already, the elderly and the newborn. So the old and the young are at greater risk for temperature fluctuations. So as far as age is concerned, for the older adults, they may lose their ability to generate fever because of malnutrition. How does malnutrition affect the inability to generate a fever? Metabolic rate is diminished, yes? Anything else? And all those other things that I already mentioned about the older adults. So age, the young and the old, the newborns or the infants have very unstable body temperature because the immature thermoregulatory mechanism in the older adults, all the things that are listed here. You'll deal with those newborns and infants next semester and how to keep them warm. An older adult who's kind of cold may have a temperature of like 95 degrees. Did anybody come across anyone that had a temp of 95 degrees? Not that low. They keep the nursing homes and the facilities where we were pretty warm. Did you notice how warm they keep the place? Yeah. Because they know that older adults will feel very cold because they can't maintain body temperature very effectively. The next factor that affects temperature is diurnal variations. Diurnal variations are also called your circadian rhythm, your body's 24-hour rhythm. It changes as the day goes on. So your body temperature changes very minimally during the daytime, but it can be as much as 1 degree or 1.8 degrees Fahrenheit, 1 degree centigrade between early morning and in the evening, afternoon and evening. So it can vary by a degree. The lowest temperature is between 4 and 6 a.m. The highest temp usually between 6 p.m. and midnight. During a lifetime, your body temperature varies less than 1 degree centigrade or 1.8 degrees Fahrenheit. Sometimes if you're working on the night shift, even the staff gets cold. So you the nurse, the caregivers, have that circadian rhythm as well. Patients at night may request extra blankets because they feel colder. And then sometimes if you're working the day shift, you come in and the nurses are wrapped in bath blankets. And they've cranked the thermometer up so it's really nice and toasty warm, but you come in fresh. Your body temperature is at, you've already passed that 4 to 6 a.m. by the time you get to your shift at 7 a.m. So the day shift comes in, it looks around and says, oh my gosh, it's like a furnace in here. Why is it so hot? Well, that's because their circadian rhythm, their body temperature drops at night as well, so they're cold along with the patient. The nurses can't really, cover up with blankets and crawl into a warm bed, so they'll have jackets on and they look very, very cold. Then the day shift, turning the thermostats down because we have to get to work and we're all warm. Other factors, exercise. I know we have a couple of runners here. Who's the marathon runner? Didn't we have a marathon runner? Who? Where's Janet? Oh, Janet. So, what happens to your temperature if you're running a marathon? It does what? It goes up. What makes it go up? The exercise. How does the exercise make it go up? Yeah, what's moving if you're running? What's really working hard? Your muscles. And muscles generate a lot of heat. So if you are running that marathon, at the end of the marathon, usually there's like a first aid tent, right? And if someone is really not doing well at the end, what are they giving them? Milk. Oh, but besides, if they're really not well and they're laying on that gurney, they're not going to give them milk. What are they going to give them? IV fluids frequently, because they become dehydrated. They have generated a lot of heat. They have increased body temperature, lost a lot of fluid over, how many hours does it take to run a marathon? 3 or 4? 5 or 6? Depending on how quickly you get to the finish line, I imagine. But, that's a long time to have continuous exercise. And then hormones is listed next. Women experience more hormone fluctuations than men do. And in women, progesterone secretion at the time of ovulation raises the body temperature by 0.5 to 1 degree Fahrenheit. And that's why women who are trying to get pregnant will take what they call basal body temperature to get a sense of when they're actually ovulating as the greatest opportunity to get pregnant. Stress, stimulation of the sympathetic nervous system can increase the production of epinephrine and norepinephrine, so that will also affect your body temperature. It increases your metabolic rate and heat production, so you have an increase in temperature due to those stress hormones. And then the last one is environmental extremes. Those are the ambient temperatures. Outdoors could be indoors. Too hot or too cold without proper clothing will affect your body temperature. So we're going to talk mostly about the environment being the outdoors rather than indoors. But during the summer when things are really hot sometimes, they'll say check on your neighbors who are perhaps living alone, check to make sure that they're in an environment where they're not getting overheated. Sometimes they'll use the malls for cooling stations or cooling centers. In the winter, they do the same thing. Check on your neighbors to make sure they're not getting too cold. Check to see if they have enough heat so that they don't become hypothermic. And keeping an eye on making sure that if you're outdoors and it's cold, that you have proper clothing, and same with the heat, that you're not out there with a winter coat on when it's hot outdoors because you get overheated. Smoking, eating, and drinking affect your body temperature, so therefore someone that has just smoked a cigarette, has just had breakfast and they drank their cold milk or they had a cup of hot coffee, you have to wait 30 minutes before you can take an oral temp to allow that temperature of the oral cavity to equilibrate back to what it normally would be without having had contact with the hot or the cold fluid. Infectious agents can also cause an increased body temperature. And what kind of infectious agents would cause increase in temperature? Did anybody have a patient who's had a fever? No? Nobody had a fever?
Strep throat.
Strep throat. Okay. So what caused it? Bacteria, right? Okay. Could it be a virus that causes? Yeah, absolutely. So infectious agent. Okay. I think I've pretty much already talked you through this pathophysiology of a fever. So it talks about exogenous or endogenous pyrogens. What are exogenous pyrogens? Remember that from physiology? What are those? X meaning from inside or outside? Yeah, exogenous, those are organisms that originate outside the body. So the example would be the bacteria that causes a UTI, the bacteria that's inhaled that causes pneumonia. How about endogenous pyrogens? What are those? It's caused by structural or functional failure of an organ. It could also be in patients who have had TB in the past, and then they become immunocompromised, and that TB becomes activated again, causing perhaps a fever. So it could be an infection that's reactivated by a dormant organism. Could also be viral. What would be reactivated if you have some sort of dormant viral infection? Give me an example. Shingles. Because those shingles, originally the person probably had chickenpox. That virus never leaves your body, stays dormant until you have an illness or disease or a combination of age and illness, and then that virus resurrects itself, right? It's reactivated after it's been dormant for a long time. So that's sort of the pathophys of a fever. So those metabolites trigger the cascading events that increases the set point of the temperature regulation in the hypothalamus. Okay? And then if you have the higher set point, you have peripheral blood vessel vasoconstrict, decreasing heat loss through the skin. Okay, and the opposite is true with the lower set point. Okay? There's more pathophys of a fever. We talked a little bit about this already, that first you start with vasoconstriction, and then you have the piloerection, thickens the body's insulating, that should say insulating. It should be a space between the insulating shell. If that's not sufficient, then shivering is triggered, but because we care for patients who are sick, look what happens when you shiver. It increases oxygen consumption by 100 to 200%. So if you're caring for that patient who has COPD, do they have any reserve of oxygen at all? No, they have a really high CO2 level already. So it increases oxygen consumption 100 to 200%. So that patient's going to have a real major deficit between oxygen demand and the supply available if they start to shiver. It increases metabolic demand by 400 to 500%. That's huge. Patients who we care for are already very sick. It increases myocardial work, carbon dioxide production, and eventual lactic acid production. So lactic acid, the patient gets lactic acidosis. So not a good thing to allow a patient to shiver. So that's why we usually monitor patients very carefully who have hyperthermia, hypothermia when their fever starts or whatever, to make sure that we prevent them from shivering. You're going to take care of lots of patients who have a fever, and there may be different types of fever that these patients will have. An intermittent fever is a temperature that alternates at regular intervals between periods of a normal temperature and a fever. And it could be normal and a lower temperature. So intermittent means that at times it's normal and it alternates between too high or too low. But usually it's too high. And we see that with bacterial and viral infections. Also in patients who have acute pyelonephritis. What is that? Kidney infection. So intermittent fever alternates at regular intervals between a high and a normal temperature. Some patients have a remittent fever. And remittent fevers have really wide fluctuations, more than 3.6 degrees Fahrenheit, that occur over 24 hours, but all temperatures are above normal. So remittent, they're all above normal, but they go higher. They go way above that, come back, but they're never at the normal level. So they may fluctuate like from 101, 103, 102, back to 101, 99, back to whatever, but they never go back to the normal level while they have a remittent fever. We see that in patients who have pneumonia and endocarditis. And how do you check to see what kind of fever they have? How do you determine this, if it's remittent or intermittent? You're tracking it on the chart. Where do you track this? On the graphic. And many of the electronic medical records, as soon as you put in a temperature, you can go to the electronic medical record and actually see the graph of the temperature. So you can see if it's intermittent or remittent or whatever other type of fever the patient might have. Okay? And always look at the previous temperature taken on the prior shift. So if your temperature is high, look and see what it was the previous shift. It may be even higher, or it may be coming down and less than what it was prior on the previous shift. So it gives you a sense of whether they're getting better or sort of in a status quo situation. There's a relapsing fever, also called a recurrent fever. So a relapsing or recurrent fever has very short febrile periods, where short periods of having an increased temperature, often for a few days, and then it's interspersed with perhaps a couple, 1 or 2 days, of a normal temperature, and then it goes up again. So relapsing, recurrent. Relapsing meaning it goes back to normal and then it comes back, so it recurs. We see that with Hodgkin's disease and things that we don't see a whole lot of, yellow fever or rat bite fever. But every now and then we see someone who has traveled and they may come in with yellow fever. So you may see those type of relapsing recurrent fevers. And then the other type of fever would be a constant fever. A constant fever has minimal fluctuation of the temperature, but all of them remain above normal. So patients who have pneumococcal pneumonia would have a constant fever. And also patients who have CNS problems, central nervous system problems. Those head injury patients may have a constant fever. The ones that are critically ill, and you'll see those in the 4th semester in the ICU. Sometimes patients have what we call night sweats. They have a fever just at night. So it occurs late evening or during the night, and it's generally always associated with TB, yes. So if you have night sweats, that is often indicative that you have TB. Okay, there's another note here. Note that the thermoregulatory basis of fever is very different from that of hypo or hyperthermia, okay? So if you're outdoors and you get caught in some snow bank, or you get lost and you're out in the cold overnight, or you're in the desert in Las Vegas and your car breaks down and you're wandering around, that sort of fever or temperature increase is different from the cause, these causes where there are disease processes going on. Okay, so the mechanism is very different. You're going to take care of patients beginning next week who will be post-op patients in many cases. So if you have a patient who is post-op and it's within 24 hours, one of the things that's always ordered or always required for the nurse to do is turn, cough, deep breathe, post-op. And we give them that incentive spirometer as well to remind them that they have to deep breathe and cough. Okay, so if you have a patient who is 24 hours post-op and develops a fever, the doctor will often give you an order to turn, cough, deep breathe, and use that incentive spirometer religiously. Why? What's causing the fever 24 hours post-op? It's not an infection. The lung is doing what? I'm sorry, I couldn't hear what you said. Collecting fluid. No. What happens if you have anesthesia? Yes, the alveoli post-op can be collapsed, post-op, right? So they have what's called atelectasis. We talked about lung sounds and what we would describe as crackles, right? Crackles is that sound that you would hear that is caused by air moving through fluid in the alveoli. That's crackles. But you also hear crackles frequently post-op. And those crackles are generated by those alveoli popping open. Parts of the lung have sort of collapsed, those alveoli. And as you take a deep breath, you can hear those alveoli popping open. So those are crackles as well. But it's not because they have some sort of problem with fluid in the lung, in the alveoli, which can occur if they do develop pneumonia later on. But certainly within 24 hours, if your patient starts developing a fever, you, the nurse, had better be religious about getting those patients to turn, cough, deep breathe, and use that incentive spirometer. How often? Every hour, as much as possible, but Q1 times 10 WA, while awake, is how you'll see the order written. So make sure that the patient, and if they're sort of groggy, wake them up. Just taking those deep breaths will help them to feel better as well, because they'll get better oxygenation of the tissues. So 24 hours post-op, if they have a fever, it's due to atelectasis. They have part of the lung is collapsed. Atelectasis means it's not expanding fully. And you need to get those patients to turn, cough, and deep breathe. Sometimes those patients, they have large wounds frequently, they've had some major surgery, and they develop a fever 2 to 7 days post-op. Not uncommon, right? So if they develop a fever 2 to 7 days post-op, what are you going to look for? What is the most common due to, do you think? Infection, but what kind? Bacterial, okay. But where is it, do you think? The wound site. And a very common reason for that temperature increase 2 to 7 days post-op is because they had or have a Foley catheter in place. We try very, very hard now to get that Foley out as quickly as we can. We used to see all kinds of people with Foley catheters post-op, and they just stayed in almost till they were discharged. Now there are pretty uniform standards that we try to adhere to, and that is that Foley catheter comes out, unless contraindicated, within 24 hours of the surgery. Okay, so that's important to keep in mind, that is a huge potential source for a UTI, for an infection. If whoever put it in wasn't absolutely conscientious and put it in using absolute aseptic technique, they are at great risk of developing UTI. I think I read some statistic, and I think it's 60% of patients who have a Foley catheter developing UTI because it wasn't inserted using aseptic technique. The Joint Commission has looked at these hospital-associated infections. What is that called? A nosocomial infection, because so many patients have negative outcomes because of these UTIs post-op and the fever, and it increases the length of stay. It also increases their risk for continued problems post-op after discharge. So if you think it's a UTI or it's a wound infection, how will you know? Yeah, so you're going to look at the WBCs, you're going to look at the CBC that's drawn almost daily on these patients, and you're going to look at the white count. If you suspect it's a UTI, what will you want to review? What are you monitoring? Urine? Output? The output's not going to be affected right away. But what are you going to look at when they urinate? The color? Odor. It's going to smell foul if they have a UTI. And what else will you see? It'll be cloudy. But not all cloudy urine is infected, by the way, okay, especially in older adults. So you're going to check the WBCs, and when you do the dressing change, you're going to look to see if that wound shows signs of infection that may be causing that fever. If you have a patient who develops a fever 5 to 7 days post-op, and often these patients are already at home or they're in a rehab facility. So if they develop that fever 5 to 7 days later, it's an deep intra-abdominal infection, or it could be osteomyelitis if they've had like a total knee, a total hip, some sort of surgery requiring open access to the musculoskeletal system, to the bone, okay? So intra-abdominal wound infection, very deep wound infection, so they might have an abscess. Let's say the wound is still sutured, but they may have a very deep abscess. What's an abscess? What causes an abscess? No? You will have swelling with it, but that's not the underlying cause of the abscess. Yes. The wound has not, there's wound drainage that can't escape. Many wounds will have a post-op drain. If that drain was removed too soon, or for whatever reason, there is wound drainage that isn't able to be collected, drained out of the wound site, it starts just collecting and encapsulating itself frequently, and that becomes infected, and you have what's called an abscess. They have to do incision and drainage, so they have to open up the incision again, put a drain in it, and then you can't close the wound again, so the wound stays open, and you have to then allow that to heal from the inside out. So 2 to 24 hours post-op atelectasis would cause the post-op temperature. So turn, cough, and deep breathe. If you're auscultating those patients' lungs, what are you going to hear if they have post-op atelectasis? Crackles. And those crackles are caused by fluid in the alveoli? No, by those alveoli popping open with the deep breath. 2 to 7 days, we suspect a wound infection or UTI. So you're going to check the white count, you're going to check the labs. WBCs would be elevated, and you're going to check if they've had any sort of change in what the wound looks like. If a wound becomes infected, what do you think it's going to look like? May look very red, may have increased drainage, may have purulent drainage. You can tell if a wound is nice and pink and healing versus an infected wound. Sometimes just like 1 or 2 stitches might have some drainage coming out of it. You would culture that, send it to the lab, and culture to see if in fact there's some sort of organism in there that may be causing a wound infection. And then those 5 to 7 days, they need to contact the physician because you really can't see it, but they'll have a fever. In some cases, that wound may be opening up and dehiscing as well. But deep tissue infection or bone infection. What time am I supposed to be out of here? 1:45. That clock is, never mind. Oh, it's almost time, so, right? Yeah. That clock wouldn't throw, I was looking at that, and I thought, oh my gosh. You didn't say anything. I didn't hear people packing up. I'll catch you guys tomorrow since it's time to go.